following is a production of West Virginia Public Broadcasting.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University. Welcome to Doctors on Call. Tonight's topic, shoulder problems. Two experts are here to answer your questions. Now here's your host, Dr. Raleigh Sullivan.
Good evening. Whether you feel a twinge of pain every now and then during certain activities or have chronic pain that affects movement in your everyday life, shoulder problems can be frustrating. It may be a problem with your nerves or permanent joint damage from arthritis or injury. So when should you see a doctor? What surgical options are available for you? How do you prevent further injuries or damage to your shoulders? We'll get answers to those questions tonight and more from our two guests. First, a familiar face for fans of Doctors on Call, frequent host Dr. Joe Prudhomme. Dr. Prudhomme is a WVU orthopedic surgeon and specializes in upper extremities. And Dr. Benjamin Moorhead, who is an internal medicine physician at WVU who specializes in sports injuries. If you'd like to ask our guests a question, give us a call. Our phone lines are open now. So, Joe, let's start with you. You know, rotator cuff injuries are common and can be quite painful.
Yeah, Raleigh, that's exactly right. If you live long enough, almost everybody gets a rotator cuff problem. By the time we're 80% of people have a rotator cuff tear in at least one shoulder. Most folks start having symptoms in their 40s. Gotten to experience it myself, and I think you might have had an experience with it as well. It's very, very common.
Very common problem. So obviously we're going to get back and talk about that some more. It's one of these things you hear about all the time, and I'm sure people are going to have questions about it. But Ben, let me get you into it. I'd like to get people involved here as quick as possible. And I wanted to ask you about dislocated shoulders. It seems like when you get those, they just reoccur, and I'm wondering whether just popping them back in is the only option or if there's other treatments.
Well, of course, there's other treatment options with that, and part of it depends on how the initial injury occurs as to what you want to do. We know that particularly younger adolescent teenagers with traumatic injuries, frequently the younger you have it, the more likely you're going to have a recurrence. Also, if it's more of a minor trauma as opposed to a bigger injury, it's more likely to recur. If you've had one injury, typically we treat that by reducing the joint. A lot of times we will put someone in a brace for a few weeks to hold their shoulder in place and then do some physical therapy to strengthen and support the shoulder. If they have a second injury, particularly before the age of 20, it's very likely to become a chronic problem. And at that point, we will typically talk about surgical options basically to stabilize the shoulder joint. Interestingly, as we get older, our age actually works in our favor. And a lot of times people who are a little bit older have a shoulder injury. They're actually less likely to have a recurrence after they go through the rehabilitation process.
You know, it's interesting. I have to ask you about something because there may be confusion out there with the audience. When you talk about reducing a joint, it probably means something different to you than it would the audience.
Yes, I'm sorry. Basically, that means putting the joint back into place where it's been dislocated, it's been out and out of position. Basically, taking the arm and putting the arm back into the socket of the shoulder joint. Now it's probably a good time to talk a little bit about the anatomy of the shoulder.
Yeah, let's just do that. Okay.
And with that, basically, there's a couple parts of the shoulder. Obviously, you have the collarbone comes across, and that's basically the boom that holds the shoulder and anchors it.
The collarbone's got like a boom.
Yeah.
Okay.
And that anchors out to the edge of the shoulder blade. And then that's where the main shoulder joint hangs off of, and the arm bone connects into there. And it really is what we call a ball and socket joint. And it's more like a golf ball sitting on a tee, where there's really not a lot of support there in the joint itself. And most of that support comes from the muscles and the ligaments around it, which is why it's very easy to see that how that joint can get dislocated, basically come off and get stuck out of position.
Well, that's interesting. And I kind of want to follow this along. Because I think all of us remember when we were kids, knowing people that had problems with dislocated shoulders. I mean, what is the basic problem there?
The T actually is fairly flat, and it has a cartilage bumper that runs all the way around. It's called the labrum. And that cartilage bumper effectively makes the T twice as big. When the shoulder pops out of place the first time, in most instances, it rips off the front edge of that cartilage lip, and it no longer has that restraint. It's kind of like having a parking lot bumper, that concrete thing that keeps you from going over the hill. You lose that, and it's a lot easier to roll over the hill, and that's exactly what when the shoulder comes out repetitively, we know that you've usually torn that bumper off. So the surgery actually goes in, replaces that bumper, and sutures it back down to try and get it to heal back into place.
Well, so let's finish this sort of line of questioning then. When do you decide to do surgery? I mean, how does that decision get made?
Typically, I would make that decision after I've had multiple dislocations. Again, as someone who's younger, has a second dislocation, it's much more likely. If those dislocations occurred very remotely, maybe 10 years apart, I would still consider to try without surgery.
Mm-hmm.
We have pretty good statistics on that. We know that men are more likely to dislocate it again than women, and the younger age you are, the more likely you are to dislocate it. If you play an overhead sport and have your arm in the throwing or racket position, or if you play any contact sports, even things as benign as basketball, we would still call a contact sport, where somebody might grab your arm and pull it back.
Right.
Very likely to occur again. I give everybody a first chance. I never operate on first-time dislocators. But if a 16-year-old boy who plays football dislocates his shoulder a second time, then I'm going to recommend surgery, because each time it pops out, you potentially damage the cartilage on the head of the arm bone and can cause accelerated arthritis in that joint.
Is surgery usually pretty successful?
Yeah, it's very successful. The more, again, the younger you are and the more violent your sport, the more likely it is to come out again. But it's at least 80% successful in those settings.
Okay, good. Well, we have our first caller. This is Barb from Ohio County. Barb, welcome to Doctors on Call. You have a question for us?
Yes, sir, I do.
Okay.
I have had surgery in my right shoulder. I've had the laparoscopic shoulder surgery on my right side. Now, I've got a question regarding, I've had several cortisone shots in the past in my left shoulder in the 90s. Now, would that be affecting me? Because I've also had elbow surgery on the left side and right elbow surgery on the right side. Why would I be having why should the pain be going down to my elbow and then into my wrist? Is that normal? Or should I see my doctor? Or should I go right straight to the emergency room for the pain?
Wow. Is that pain on the side that you had the surgery?
No, it's not. It's on the opposite side. I don't know if it's scar tissue damage. I don't know. I mean, it starts in the left side of my neck. It goes into my left shoulder, and then it goes right down to my elbow where in the left elbow. Yes, sir, I'm sorry. Mm-hmm. And then it goes into my wrist, and it's a constant aching, throbbing, pounding pain.
Do you ever have any numbness or tingling associated with that?
No, I haven't, sir.
You know, whenever the pain goes down below the elbow, we worry about it being something other than the shoulder causing it. And a real common cause is a pinched nerve in the neck. So when you talk about continuous pain that starts at the base of your neck and goes all the way down to your wrist or hand, we always check for a nerve problem in the neck, and that's something that you really need to consider in addition to the others. It's possible you could have a separate shoulder and elbow problem, but very likely you've got a pinched nerve in your neck that's causing this.
Let's talk about back to frozen shoulders, if you would. Can you sort of describe what goes on in a frozen shoulder? It's a very common term, and I think most people have heard of it, and I suspect there's a lot of confusion about really what it is.
I'm going to let Ben talk about that a little more. He probably sees more frozen shoulders than I do even.
Yeah, frozen shoulders are a fairly common entity that people have. Most commonly it happens without a reason. There's no injury, it just begins. frequently you notice first just losing a little bit of motion. Most commonly it's reaching behind your back is the first motion to go away. And then shortly after that, people typically begin to have some pain in their shoulder. Again, like I said, most of the time there's really not a cause. It can be associated with other illnesses, particularly diabetes is where we commonly see it. Typically people in their 40s or 50s.
What did you say, 40s or 50s?
Yes.
Uh-huh.
With this, basically, like I said, just slowly losing motion and getting pain in the shoulder. And it's caused by some inflammation of the capsule and thickening of the capsule that tightens down and restricts that motion. It can be an extremely painful entity. It will get better over time on its own, typically somewhere around 2 years if you don't do anything. We think that doing some treatment, including physical therapy, working with the motion of the shoulder, sometimes in combination with an injection to the shoulder, we can at least keep you comfortable and frequently can speed up that process a little bit as far as the time to recovery.
Only because it's kind of a personal issue to me, as we've talked about before. I may come back to it, but we have another caller. This is Amanda from Mercer County. Amanda, welcome to the show. You have a question for the panel?
Yes. I'm 67 and I have a degenerative disease. I cannot pronounce it. But I'm wondering if my shoulder pain is the beginning of paralysis in my shoulders and arms, or if it's coming from something else.
Is your degenerative disease in your nerves in the arms and legs, or is it something that's degenerative at the level of your brain?
I was told that I would lose control and I'd be paralyzed in my arms and legs at some point.
How long have you had this?
About 7 or 8 years.
She's 67, she said.
Well, Amanda, the good thing is if it's been going on 6 or 7 years and you're still moving, that's a good sign, and I hope that you continue to do well. Those are always iffy things, and they can cause disproportionate pain, and they can be fairly painless. So that is something, without knowing exactly which disease you have, I would have a hard time predicting. Ben, can you shed any light on that for her?
Unfortunately, it's difficult, and it's possible even with different diseases that it could be indirectly causing a separate injury in the shoulder because of some of the progression and loss of motion. It may be putting more pressure across the rotator cuff. There may be a separate entity or tear going on at the level of the shoulder, or it could just be related to the degenerative process itself.
Your doctor certainly could check it out, and by examining you could have a good idea whether it was coming intrinsically from the shoulder or whether it's part of the underlying process, I would think, though.
Yeah, I would definitely recommend specifically addressing the shoulder pain issue with your personal physician, and then going from there whether to see a specialist or not.
Okay, sounds reasonable. We've got another caller. This is Gerald from Nicholas County. Gerald, welcome to the show. You have a question for us?
Yes, sir, I sure do.
Okay.
And good to hear you, folks. I watch you about every week.
Well, good.
I was working my left shoulder, and I kind of pulled it like about a year and a half ago. And I thought maybe it messed up the rotator cuff. I'm 78 years old now, and I was 77 man. And I just wanted to say that I went to the doctor here the other day and x-rayed it, and they said it was severe arthritis had set in there. And I was wondering if any injections or anything like that would help me, sir.
Well, he's leading right into where I wanted to get to anyway, so who wants to take it?
Yeah. Well, with arthritis, there's a couple of different options. Frequently, if your motion's still good and your function is good and it's just pain, a lot of times an injection is the best treatment option that can give us some long-term, typically meaning several months to a year of pain relief, and often we can repeat that injection if needed. Now, if you have significant loss of function and loss of motion because of your arthritis, you may be a candidate for a joint replacement for the shoulder as well. And it really just depends as far as what your level of function and what your level of comfort is. Typically, where I recommend starting with that is with an injection as the first level.
It would be injection of?
Basically injection of a corticosteroid, which gets rid of inflammation, which is frequently what's the source of the pain from the cause of the arthritis.
How many times would they have to get the injection? I'm just curious. I mean, is it a series, or can just one injection do it?
Well, we can repeat the injection if needed. Sometimes people will have a good response, get rid of the inflammation. And actually, arthritis is a funny thing, and sometimes it can wax and wane, and it can settle down. It may not be a problem for several months or a few years even. And then at that point, if it's painful again, could look at doing another injection.
You guys are getting me thinking about all sorts of things here that I want to ask you, but we have another caller. This is Mark from Washington County, Pennsylvania. Mark, welcome to Doctors on Call. You have a question for us?
Yes, sir. I was operated on a rotacuff surgery in August of 2010, and also some bone spurs. And I had a lot of trouble after the surgery, so I went back in for manipulation in January of this year, and I feel worse now. I'm still having a lot of pain from my shoulder up into my neck, and I was wondering what the doctors felt that maybe that I should do next, or I'm just not getting any better. No, much more movement up above or anything.
How many years young are you, sir?
I'm 55.
And after your surgery, how was it treated? How long did you go without moving it under your own power?
Probably for at least a couple of weeks, 3 weeks. I did my therapy at home, and then after that I went to rehabilitation.
All right. Well, rotator cuff repairs, unfortunately, are not 100% successful. The rotator cuff tear is kind of like the knee of your old blue jeans wears out. The material gets thin and then makes a rip, which can spread. And when we fix it and sew it, we can slow down the progression of that disease, but we can't stop it. So if you have those jeans long enough, they may tear by the edge of the patch, or the stitches may tear through the material because it's thin. One possibility is that your repair tore out and did not work, wasn't successful. Sometimes that can be fixed again and sometimes not. Another possibility is that you have scar tissue that's restricting your mobility, and that's what's causing your pain. And so it would be important to differentiate between those two. So I would go back and have your surgeon check you again, make sure that he understands that you're still having trouble. And then if there's still a question, many times if we do an MRI scan and put a contrast injection in the joint, put dye inside your joint, it will tell us if the repair worked and if the rotator cuff is intact, and it will also tell us if there is scar tissue adhesion. So that's what I would be thinking about in your case. I'd go back to your surgeon, and if he's not sure, ask for an MRI with the contrasted dye injection into the shoulder joint to see what's going on.
Sounds reasonable. We have another call. This is Larry from way south in West Virginia in Wayne County. Welcome to the show, Larry. You have a call or a question for us?
Yes, I do. It's about a frozen shoulder. And what it is, I was in trauma in a motorcycle wreck, and I'm just getting the effects of a frozen shoulder. I'm going through therapy now. But I had this numbness and tingling in my left hand at the same shoulder that's bothering me. And actually, I had cervical neck fusion. I was wondering if this frozen shoulder would affect the nerves for the tingling and numbness in my hand.
How old are you, sir?
I'm 46.
How long ago was your injury, your motorcycle wreck?
Motorcycle wreck was August 15th last year.
And your surgery on your neck was shortly thereafter?
Actually, it was January 21st of this year.
Okay. And was the numbness and tingling going down your arm ever since the time of the wreck, or is that something which has come on later?
Yeah, as soon as I gained conscious, I noticed I had numbness, and it's still going on after the surgery.
Perfect. Many times in a motorcycle wreck, unfortunately, the shoulder is pushed down, and the big helmet pushes the head the other way, and it stretches the nerves as they come out of the neck and go down into the arm. It's called the brachial plexus. And unfortunately, I take care of a lot of motorcycle riders. I love it, riding myself. But that is an injury which is really common in a motorcycle wreck, is actually stretch those nerves as they come out of the neck, pass through the shoulder, and go down the arm. And those injuries are tough to treat, and will get better with time for up to 2 years, but they seldom ever fully recover. So if they have treated your neck and done a successful job of that, this may well be a result of a stretch injury to those nerves, unfortunately.
So time is what he needs to...
Time, physical therapy, and somebody who's used to looking at brachial plexus injuries to see if they think that that's in fact what's going on with him.
Mm-hmm. Do you want to describe, either one of you, the sort of normal aging of the shoulder, what happens as we get older, and how common that problems are just in general?
Sure, Ben, go for it.
Okay. Well, with aging, like you said, it commonly get injuries to the rotator cuff. Most commonly, it's sort of a wear and tear process with that rotator cuff, particularly as we reach our arm overhead. That rotator cuff can get pinched across, basically between the top of our shoulder blade and the arm bone is where that rotator cuff sits. And I should explain what the rotator cuff is tendons, and tendons are what attach muscle to the bone. Mm-hmm. So as those muscles are pulling to move our shoulder, at the same time they can get pinched in there in certain positions, and most commonly that's overhead. Then over time, because of that constant wear, they actually lose their strength. They don't hold the shoulder in position, and it's even more likely for it to tear. So that's why it's very common with age to have injury to that rotator cuff. Interestingly, the pinching occurs more on the top of the rotator cuff, but most frequently we see the tears on the underside of the rotator cuff, and it's thought to be more due to the mechanics of how that arm is sliding than truly the pinching, but they're both definitely related to each other.
You talk about this. This is just sort of what happens in aging, and it's wear and tear. Is there anything that people can do about this?
To a degree, but it's just one of those, it's sort of the weak link. The tendon which is responsible for greater than 90% of rotator cuff tears is the one on the top of the shoulder, and unfortunately it's the smallest tendon, and it has to do the biggest job. And it gets pinched like a nutcracker between the edge of the scapula and the humerus bone. When you raise your arm up like this, it actually crimps that tendon each time you do it. So the more work you do with your elbow away from your body up over your head, the more often you pinch it. But a lifetime of wear, is going to wear something out, and unfortunately, that's the weak link in the shoulder, is that little skinny tendon on top.
So physical therapy.
Physical therapy can definitely play a role, particularly when it's injured, and it plays a role from two different components. One, actually strengthening that part of the rotator cuff, which is called the supraspinatus, and it's a muscle that goes around your shoulder blade. By strengthening that, it can make it a little bit stronger. The other thing is there's other components that stabilize the shoulder that allow it to have more pressure on the rotator cuff. And most frequently, that's the muscles that hold your shoulder blade in place. So by doing some therapy to focus on strengthening the shoulder blade muscles, sort of your upper back muscles, holding that shoulder blade in place will take a lot of pressure off that rotator cuff. And usually a combination between the rotator cuff strengthening and the upper back and shoulder blade strengthening can cause or can help the rotator cuff significantly.
Well, that's interesting.
I'll second what Ben's saying about the shoulder needing physical therapy. Physical therapy is a great help. Part of it is just the passage of time. When a shoulder gets hurt, it goes through an inflammation repair process that lasts a minimum of 3 months and can last 6 months or longer. But during that time, the rest of the shoulder suffers, and what you want to do is keep the rest of the shoulder strong and in good working order while the hurt part heals. And a lot of therapy is doing that, is keeping the rest of the tendons, which are not harmed, working well, because the whole thing is sort of punch drunk, and your shoulder, when it's sore, starts working funny. And the physical therapists get all the rest of it that's not hurt in proper working order, so when the tendon that's hurt heals, it's ready to go.
That's interesting. I never thought about that. Listen, we have another call. This is from even further south. This is Cynthia from Kentucky. Welcome to the show, Cynthia. You have a question for us?
Yes, I have. I'm 46, and I have tendonitis in my shoulders. And I was wondering what I could do about that.
What have you done so far for it?
I'm not sure what to do about it. I'm not sure if I should go to physical therapy, or there's no doctors here that know anything. I can't find any doctors around here to take care of the problem, so I don't know exactly what to do about it.
Have you had an x-ray, or who told you that you had tendonitis?
I had an MRI on my shoulders, both of them.
Okay.
And
Well, that's very good that with the MRI, then that definitely rules out a tear or other significant problem. Really, the MRI is one of the ways that we can know that you definitely don't have a tear, or it's very unlikely that you don't. Really, the mainstay with the tendonitis, the mainstay of therapy is physical therapy, which is doing some modalities, which basically is a way to give some pain relief, as well as doing some strengthening, as Joe was saying, not only to that affected area, but to the other components of the shoulder to stabilize it, to make sure that the shoulder is moving functionally. Medications can also help as well. Frequently used anti-inflammatory medicines, which are similar to like Motrin or naproxen over the counter. And your doctor may prescribe that as well. But I would recommend asking your doctor about it and trying to get in at least with a physical therapist. And if they're not comfortable doing that, then I think, talking to them about seeing a specialist, it would be a good idea.
Well, we only have about 15 seconds left. You want to add anything to that?
More than any other part of the body, I use physical therapy for the shoulder. And I think if you haven't done therapy, unless you had a traumatic accident that started your shoulder pain, physical therapy should be the first step for almost every shoulder problem that didn't start with an accident.
Great. Sounds terrific. Listen, we've been talking about shoulder problems with Dr. Joe Prudhomme and Dr. Ben Moorhead. Thank you both for being with us. If you'd like more information, talk to your family doctor or visit us at wvuhealthcare.com. For Doctors on Call, I'm Dr. Raleigh Sullivan. Good night and good health.
Join us again next week for another edition of Doctors on Call. Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
This has been a production of West Virginia Public Broadcasting.